Well, good morning, everybody. It's a great pleasure to be here at this first Cardiomyopathy UK conference. As Alison said in her opening statement, this is a unique moment for the charity where we build on the international reach that we've had for the past 20 years or more. And we're now talking to people around the world with cardiomyopathy. And we hope that you're going to enjoy today, learn from it, and enjoy the interaction. My talk today is on hypertrophic cardiomyopathy and my second on restrictive cardiomyopathy. So if we begin with maybe a scene setting, cardiomyopathy, really difficult word, isn't it? But all it means is that you have a bad heart muscle. And that bad heart muscle is not explained by other common conditions such as coronary artery disease, high blood pressure, or valve disease. When we talk about different types of cardiomyopathy, whether it be hypertrophic or dilated or restrictive, really all we're doing is describing what we see when we take a picture of the heart using an echocardiogram or MRI scan. So when we're talking about hypertrophic cardiomyopathy, we're referring to the fact that the heart muscle is thicker than it should be. In the case of dilated cardiomyopathy, the size of the chamber of the heart is increased, but the pumping function is reduced, and so on. So these are descriptive terms. In the case of hypertrophic cardiomyopathy, this is what it looks like. This is a section through the heart, and you see here the left side of the heart, the right side of the heart, and in between the wall here, this is grossly thickened. And it's this that defines the condition. We measure the thickness of the heart muscle, and if it's increased, that's all you require to make a diagnosis. Here is the equivalent of that when we look at an echo scan. So once again, this is the right side, this is the left side, and this is that muscle between the two chambers, what we call the septum. And you can see here that this is very thickened. What you see here is the top chamber of the heart, the left atrium, the mitral valve. And if you look very carefully, there's this valve sort of flipping forward slightly. And I'll come back to this because this is an important feature of the disease. But this slide, which is meant to be a little provocative, is that hypertrophic cardiomyopathy, HCM, is not a diagnosis. As I'm trying to explain, this is a description of what we see when we take pictures of the heart. And this applies to all different types of cardiomyopathy. Because when we make that first classification, what we then have to ask is, why is this heart thick? Why is this heart dilated? Because there are families of diseases, whether some of them are genetic, some of them are non-genetic, that can explain these different cardiomyopathy subtypes. In the case of hypertrophic cardiomyopathy, the majority are probably genetic, so they are inheritable. And the largest group within hypertrophic cardiomyopathy are people that have genetic mutations, spelling mistakes in genes that make up the proteins of what we call the sarcomere. This is, if you like, the motor of the heart muscle, the thing that makes it contract. And the schematic shows some of these filaments that slide across one another, and the genes that make the proteins of this structure have all been implicated in the disease. This again is a cartoon showing what happens at a molecular level inside the heart muscle with this interaction between these proteins making them slide across one another. And it's the genes that make these different proteins that cause hypertrophic cardiomyopathy. But as I've said, there are many, many different causes. This is taken from the 2014 European guidelines for the condition. And our best guess is maybe 40%, maybe 50%, maybe 60% at a push. People with the condition have mutations in these genes that I've been describing. There is a slice of people that have a thick heart for whom we cannot find the cause, but that slice is getting smaller and smaller as we discover new genes. And then there's a group of 5 to 10%, maybe more, of people that have some of the conditions listed on the right here. Now, some of these are genuinely very rare. Some of them, however, are rare because they're not routinely looked for in clinical practice, or because they affect particular groups of people with cardiomyopathy, whether it be the very young or indeed the elderly. In terms of new approaches to diagnosis, echocardiography remains the workhorse, if you like. That's going to be usually the first test that will be used to investigate your condition. Echocardiography has been around a long time, and the technology continues to evolve, allowing us to look at the function of the heart in ever greater detail. But one of the big game changers over the past decade or more has been cardiac MRI, which allows us to look at the structure of the heart in great detail, but perhaps more importantly, allows us to look at the tissue of the heart itself. It shows us whether there's scarring or inflammation or infiltration with abnormal substances. And there are a whole variety of technologies that can be applied in MRI to characterize the heart muscle. Interestingly, in our diagnosis of heart muscle disease, we're actually using some old technologies in a new setting. And this is one which is now being used increasingly in hypertrophic cardiomyopathy. This is, as you can perhaps see from the picture, a bone scan. So this is a test which is used for looking for tumors or inflammation in bones. But there's a particular type of cardiomyopathy caused by amyloidosis, which I'll return to in my second talk of today, restrictive cardiomyopathy, where the bone scan lights up the heart, giving us a very specific test for the diagnosis of this particular subset of people with hypertrophic cardiomyopathy. Now, if we move on to the management of this condition, when I meet people in the clinic, I usually break up the discussion into three parts. The first is the implications of a genetic condition. If you yourself have a genetic condition, then what are the implications for your family members? If your family members are going to go for screening, what is the implication for life insurance, for employment? The psychology, the dynamic within a family, the sense of guilt if you have a genetic disease and you've passed it on to your children. All of these things require discussion in their own right. We obviously spend a lot of time trying to determine whether people have symptoms, to understand the mechanism of those symptoms, and if we can, to alleviate them. And of course, this box, the risk of complications. Usually by the time that people come to our clinic, they're already pretty expert on the condition themselves. They've usually seen quite a few doctors already. They've already done a lot of background research. And of course, the thing that if you put this into hypertrophic cardiomyopathy into a search engine, the thing that screams back at you is sudden cardiac death. So we spend a lot of time discussing the risk of this and what we can do to protect people. With regard to genetics, there are many things we could discuss in genetics. I'm not going to discuss that in great detail today, but I'm just going to talk about this recent paper that we've published from our own group, which addresses an issue that we've been talking about for a very long time, and that's really the value of genetic testing in family members. In hypertrophic cardiomyopathy, if you screen other family members and find a gene, at the moment, it doesn't fundamentally change the way they're treated. But what it does allow us to do is to follow them long term so that we can detect the disease when it develops and prevent complications. But what we haven't really had is an idea of how many people who carry the gene but have a normal echo or normal ECG or normal MRI scan, how many of those people will go on to develop the condition over time? And what we've seen here is actually that it's maybe up to half of people who start off with nothing but carry the mutation will go on to develop the disease over a 15-year period. Importantly, if you're not, what we say, expressing the disease, so if there's nothing visible on an echo or MRI, then you're not really prone to any particular complication. But as soon as you develop the disease, that's when we have to start making risk assessments so that we can prevent any complications of the disease from arising. With regard to symptoms, the kind of symptoms that people complain of are breathlessness, that's what this term means, dyspnea. They may complain of chest tightness or chest pains, fatigue, blackouts, or they may experience palpitations, an awareness of the heartbeat or rapid heartbeats or skipped heartbeats. And there are many different reasons why this may happen in hypertrophic cardiomyopathy, and it's very important for us, if we can, to determine why it's happening. One of the commonest reasons for symptoms on exertion is this phenomenon. What you see here is a picture of the ventricle, the main pumping chamber of the heart on the left side. And you see here the inlet valve, the mitral valve. And as the heart contracts, what you see here is that in some people with hypertrophic cardiomyopathy, the valve bends forwards and touches the muscle and gets in the way of blood as it passes out of the ventricle into the aorta and around the body. And this phenomenon we call obstruction, and this can be present all the time or only present when people try to do a form of exercise or walk up a hill or stairs. This is what you see on an echo scan. So here you see that top chamber, the ventricle is here, and here this is the inlet valve. And if you look very carefully, as the heart contracts, you see that valve moving forwards. And if you look very carefully here, this is what we call color Doppler, and this maps flow through the heart. And as the valve comes together, touches the muscle, if you look very carefully in a second here, there's a flash of blood back into the top chamber. This is a leak back through that inlet valve, the mitral valve. And that's one of the reasons why people feel breathless on exertion with this particular phenomenon of outflow obstruction. Now, how do we treat it? Well, for decades, the way we've treated it is to give drugs which, if you like, reduce the force of contraction of the heart. The harder the heart beats, the greater is the obstruction in most people. So we use drugs which are used for many other things in cardiovascular medicine. Beta blockers, sometimes we use verapamil or another drug called diltiazem. These are what we call calcium antagonists. We sometimes use a drug called disopyramide, which is actually a drug which is used for controlling heart rhythm, but almost as a side effect, what the drug does is it reduces that force of contraction and can alleviate symptoms. In some people, we may use diuretics, water tablets, although we have to use those cautiously, because if we overdo it and we dehydrate someone, then we can in fact end up making them more and not less symptomatic. Now, drug therapy, well, for 20, 30 years, I've been saying that drug therapy works in most people. I'm not sure that's entirely true, if I'm honest. I think it maybe alleviates symptoms to a degree, but it's quite unusual for drug therapy alone to completely abolish symptoms. If symptoms are severe and the drug therapy is ineffective, or if the side effects of the drug are worse than the symptoms, then there are a number of ways of trying to reduce the obstruction. One is a heart operation. And if you look at the panel on the left here, what you see here is a picture of the inside of the heart. And what we can ask a surgeon to do is to remove a little trough of muscle from that bulge in the muscle in the septum, that wall between the two chambers. The operation isn't as dramatic as this. We don't open the heart, but what the surgeon does is he opens this large vessel, the aorta, and looks down through the outlet valve, the aortic valve, and removes the muscle from above. In some cases, there's very extensive hypertrophy, and so surgeons may extend the excision to try to, if you like, debulk the septum, but that's rarely necessary. What we call a myectomy is usually sufficient. And in good hands and with an experienced surgeon, careful planning of the operation beforehand, this can be very successful with success rates of 70–80% in terms of symptom reduction. But obviously it is a cardiac operation and it isn't universally available and does carry a risk. And so for that reason, people have looked for other less invasive ways of trying to shrink the muscle. And the major one that is in clinical practice at the moment is what we call septal ablation or alcohol ablation of the septum. And what this involves is putting a catheter. I'm sure many of you watching have had an angiogram where a catheter is put into an artery at the wrist or at the top of the leg, and it's passed up the aorta using an X-ray camera, popped into the main artery which runs down the front of the heart, And then with a little balloon, we put that into a branch which supplies the thickened area of muscle. And then we inject alcohol, medical alcohol, into that muscle to shrink the muscle in a localized way. This is safer than surgery. Not everybody is suitable for this because the anatomy is not suitable, and you cannot isolate the alcohol to this localized area in every patient. But it is an option and can be successful, again, in selected patients. As I can see from the questions that we've already received, there's a lot of discussion and a lot of excitement about a new drug which has recently been, a trial of which has been recently published in The Lancet within the past few weeks, a drug called mavacamten. Now, in essence, this is trying to do the same thing as beta blockers and disopyramide, but probably does so more effectively, and it seems with a more favorable side effect profile. So it reduces the force of contraction of the heart and reduces the obstruction. And if you look at these graphs on the right here, I'll just draw your attention here. This is a measure of the severity of the obstruction. And in red, these are the people who took the placebos and were not taking the active drug. And here in blue are those people who were taking active drug. And you can see that there was a significant reduction in the level of obstruction. And this was associated with improvements in symptoms, with improvements in exercise tolerance, and improvements in markers in the blood that we use to tell us about the severity of the condition. One in particular, which is called BNP, which is used as a diagnostic test and a prognostic test in people with all sorts of heart muscle conditions. But again, you can see that there was a significant and quite dramatic reduction in this substance in the blood, which suggests that the heart muscle is under less strain or less pressure. So very encouraging results. Obviously a lot of discussion, a lot of work yet to be done, but this suggests that we have a new option now for drug therapy in the treatment of outflow obstruction. Now, a point I will make is that you always start with drug therapy, but the essence of obstruction is that it's an anatomical problem. It relates to abnormalities in the valve and the muscle and the relationship between those two things. So there are always going to be people for whom drug therapy will only be partially effective or maybe not effective at all. There are also some people that have other abnormalities that cannot be corrected by a drug. I showed you on one of those early echoes this phenomenon of mitral regurgitation. So this is a leak back through the valve that happens as it moves forwards with obstruction. Now, in some people, there are other things wrong with that valve which are causing the leak. And the only way of correcting those is with surgery. So this is why surgical planning, or at least planning of therapy, is so important. We see other anatomical abnormalities. Not only do we see thickened muscle, but we see elongation of the leaflets, or we see abnormalities of the structures which support the valve. The mitral valve is a bit like a parachute. It's supported by the heartstrings and muscles, and the abnormalities in these structures can also contribute to the obstruction. And of course, drug therapy will not by itself treat those things. So drug therapy is our first line, but there are always going to be people that require intervention with surgery or alcohol ablation. And that is why when we're planning therapy, we have to take into account the anatomy and other things. Are there other features of that individual that are determining or contributing to their symptoms? Are they anemic? Do they have coronary disease? Are they overweight? Because reducing weight by itself can improve symptoms. So planning is essential. Now, to move to the grim subject of sudden death, as I say, it's very interesting. When people come to see me, they're aware of it, they're scared of it, and often have to be prompted to have a discussion about it. I think what I try to explain when people come to see me is that this is a condition which is relatively common. You know, it may be as common as 1 in 500 of the population. 1 in 500 of the population are not prone to sudden cardiac death or the kind of things that you will read about if you search for hypertrophic cardiomyopathy on Google, for example. If you look at the mortality rates of people, in fact, I'll just go to the next slide, the mortality rates of people with hypertrophic cardiomyopathy. The orange line here is the annual rate in the normal population, and here is the annual rate in hypertrophic cardiomyopathy at different ages. And it's 1% or less chance of having any HOCM-related fatal event. It is still higher than the background in the population. So this straight line here is corrected for a normal population. And for both men and women, there is an increase over the background. Interestingly, and this is something that we've only recently looked at and discovered, is that the excess mortality is greater for women. And this is a feature that we haven't seen before. We don't really fully understand it. But this is an area that requires further study. So sudden death is a rare event, but what we have to do is to identify that small group of people who are potentially at risk and to treat them. And we've got an enormous incentive to treat them because we have very powerful ways of protecting people. You know, the defibrillator, this implantable box which can shock you out of an abnormal rhythm if you experience such a thing. Now, defibrillators have been around for a little while. I mean, maybe not as long as you might think. I mean, 1980, there was the first time a defibrillator was put into man. I'm not sure whether that was a long time ago or not. I first went to medical school in 1982, so perhaps it was a long time ago, I don't know. But since then, there have been a lot of developments in the technology so that the size of the generators have come down. When these defibrillators were first put in, it was actually a heart operation. We had to have pads put on the outside of the heart. Whereas now the wires that we use can actually be put into a vein without having to open the chest. There are still issues with these devices. I mean, if you have a device for many years, you can experience lead problems. If we have to extract a system which is malfunctioning, that carries small risks in itself. And so there is an ongoing drive to improve the technology still further, to improve the safety of the therapy. And this is one of the most recent innovations, which is what we call the SICD, where the box, rather than being put under the collarbone in the place of where we would put most conventional devices, this is put out on the side of the chest. And the wire is tunneled underneath the skin. There's actually nothing physically inside the heart. And the aim of this device is to reduce the long-term downsides of wires inside the heart. And certainly we're using this a lot now in people with all types of cardiomyopathy. Not everybody, in fact, the overwhelming majority of people with hypertrophic cardiomyopathy do not need an ICD. And so what we've been trying now for decades is to identify ways in which we can quantify the risk of an individual and then have an informed discussion about who needs a defibrillator. And we and others around the world have been involved in developing models to predict risk so that we can take an informed decision with an individual. To summarize a lot of work over many, many years, we now have this calculator, which is available online, where we try to estimate an individual's risk of having an event over a 5-year period. And there's nothing magical about it. We look at the age of the individual, how thick their heart muscle is, how big the top chamber is, whether they have this obstruction, look at the family history, 24-hour tape, look at some of their symptoms, and use this to generate a risk. And then we have an informed discussion about what an acceptable risk is to that individual. This approach now is being extended to pediatric practice, and a similar study from our colleagues at Great Ormond Street, again, has developed a model for predicting risk in children, which is obviously to some extent more challenging because you have a changing heart as young children age and move into adolescence and adulthood. But nevertheless, it does seem possible to generate risk estimates, which again can be used in those difficult decisions about defibrillators in children. All I'd say about this slide is that this is taken from the last guidelines, which I contributed to, and the way in which we work in medicine is we use these thresholds, and they're still useful, but of course there is no universal definition of acceptable risk. So this is very much a joint decision based upon the pros and cons of putting in a device in the light of the estimated risk. With regard to other complications, the other very important one that we focus a lot on is this one, thromboembolism, or in other words, stroke. And the risk of this is about 25% over a lifetime of developing a rhythm called atrial fibrillation, which is where the top chamber of the heart becomes irregular. And that is the cause of stroke in hypertrophic cardiomyopathy, because if the top chamber is irregular, you get stasis of blood inside that and clot formation. And if one of those small clots leaves the heart, it can cause a stroke or problems in other organs around the body. And the most important predictor of the development of atrial fibrillation, and therefore of stroke, is the size of that top chamber, so what we call the left atrium. And as the left atrium increases in size, then the risk of stroke also increases. So, very important aspect of our assessment of individuals with this condition is, yes, estimating the sudden death risk, but it's also looking at the atrium and trying to assess their risk of stroke. The good news is that if we initiate therapy, then we can substantially reduce that risk. There hasn't been a trial of anticoagulation in hypertrophic cardiomyopathy, and it's extremely unlikely that there will be. But if we look at our large registry data, then we can reduce the risk by between 50 and 60%, and probably more, just with the use of warfarin. We believe that the newer drugs that many of you are taking, what we call DOACs, are also probably equally effective and to some extent maybe safer in some individuals. The one important thing that we have to bear in mind, though, is that out there in the real world, many people with atrial fibrillation are not receiving appropriate therapy. And this is from work that we've recently done using electronic health records. And it was exactly the same number as we would expect. About a quarter of patients with hypertrophic cardiomyopathy had atrial fibrillation, but only 1/4 of those individuals were actually receiving warfarin, therefore exposing them to the risk of stroke. So I'm emphasizing this because this is an underappreciated but really important aspect of the management of this condition. So hypertrophic cardiomyopathy, a complex disease. It can cause significant symptoms which impair quality of life and your ability to function. We can, using the modern tools that we have available to us, assess the disease, assess the symptoms. We can prevent complications such as sudden cardiac death and atrial fibrillation and stroke. For the future moving forward, something that we are less effective at is preventing the development of heart failure symptoms. If you have this condition for 10, 20, 30 years, then some people will develop impairment of their heart function. And at the moment, we don't have drugs that prevent that. But that we're now entering a new era. I've shown you a slide on this drug, mavacamten, but there is a huge amount of activity now trying to develop drugs which have the potential to slow or prevent this, what we call remodeling of the heart, and maybe even to allow us to dream about stopping progression altogether or even preventing the disease in the first place. So I think the next 5 to 10 years are going to be a really exciting time in new drug development. So on that note, perhaps I can stop there and take any questions. So Joel, I'm not sure whether you're going to join me for this bit, but maybe I can kick in with the questions that we've received here. And top of the list, a very common question, which is, do you have any exercise recommendations and sources of information for people with hypertrophic cardiomyopathy? As I often say to people when they come to see me in the clinic, this is one of the few questions that still makes me squirm a little bit. Because this is mostly opinion-based medicine. If you Google HOCM, you will see this close association between exercise and the condition and the risk of dying suddenly. You know, I'm sure we've all seen stories, maybe even witnessed on television in prime time, young athletes who've died on a football pitch or playing some other activity, and they have hypertrophic cardiomyopathy. Therefore, it is assumed that sport is really bad for you if you have this condition. But as I've said, sudden death in hypertrophic cardiomyopathy is a rare event. And when it does happen, it often happens when people are not doing very much, either mild exercise or indeed actually when they're asleep. The real issue is actually, if you like, assessing the disease and then coming up with a prescription for exercise that allows people to have a quality of life, to maintain their general fitness, to reduce their risks of other conditions which are associated with being inactive, and balance that against a theoretical risk of something bad happening should they exercise. Most of the time, this is down to common sense. It's avoiding intense competitive exercise, sudden bursts of intense exercise. And if you do those kind of things, that actually the majority of people with this condition, exercise is a safe thing to do. There is some advice available. The Cardiomyopathy UK can provide such information. There will be a new set of American guidelines coming out this year in November, where there's actually some liberalization of the current advice, and there's a new sports guideline from the European Society of Cardiology, which also provides some detail on the approach to this. But in essence, exercise is not forbidden, but the prescription should be decided by a discussion between your cardiologist and yourself about what is safe and what is potentially dangerous. Second question I have here, which is an interesting one, which is in long-term patients with hypertrophic cardiomyopathy, what is your advice regarding having an MRI to check for disease progression and possible fibrosis? Now, I don't know who that's come from. I'm not sure whether it's from a healthcare professional or not. So as I've shown you, MRI gives us great pictures and allows us to quantify scar within the muscle. And our current advice is that it is helpful to, if you can, perform an MRI at baseline evaluation. So the first time a patient is seen, as part of their workup with echo, ECG, Holter monitoring, ambulatory ECG monitoring, an MRI at that stage allows you to stage the disease. I don't think it's necessary to do it very frequently thereafter, but maybe every 2-3 years if the resources are available. But the important tests in long-term follow-up are the electrocardiogram, the 24-hour ECG, and the echocardiogram. But at least a baseline, I think, is helpful in characterizing the condition. Obviously, this has been a concern for the past 6 months, but what do the data show us with respect to the correlation between coronavirus and cardiomyopathy clinical outcomes? Should we expect our usual checkups? And what about dental appointments? All really, really important questions. And you can imagine, I've been asked this question many times over the past 6 months. And it's been an interesting experience as someone who deals with a lot of people that have this condition. COVID is a viral infection which can affect any organ in the body, but it's principally a pneumonia. There was a lot of concern at the beginning because there seemed to be a significant excess of severe infection and mortality in those individuals who had underlying cardiac conditions. In particular, hypertension, high blood pressure, coronary disease, other vascular diseases. And because of that, it was entirely logical to advise people with cardiomyopathy, where the heart muscle may be vulnerable to viral infection or to the effect of the virus on the immune system, to shield and to avoid contact in the way in which the government advised. I think as a consequence of that, we've seen very few problems in people with cardiomyopathy. Interestingly, in the few people that I'm aware of that have had cardiomyopathy in COVID, again, we've seen relatively few problems. Now, is that because the risk is not as great as we feared? I just don't think we know. As I say, I think that correctly, people have avoided contact with the infection. And my advice remains, socially distance and try to avoid contact with the infection, follow all the current guidance. But we haven't seen this massive excess of problems in people with cardiomyopathies. In terms of usual checkups, this has been, I think, the major consequence of COVID, which is that our ability to see people with all heart conditions has been significantly compromised. But we've tried to maintain contact with people remotely. And of course, in all hospitals, people can still be seen if they have a problem. So maintaining regular checkups remains a very important issue. And indeed, actually, moving to online has actually facilitated that in many respects, avoiding long trips to hospital. And the same is true of dental appointments. Obviously, this has been an even greater challenge because of the potential risk of exposure to the upper airway secretions. But if you have a significant dental problem, again, you should be seeking advice, because untreated, that could have consequences for the heart because of infection in the gum affecting the heart. Is ablation the only surgery for ventricular tachycardia with hypertrophic cardiomyopathy? That's a very specific question. So ventricular tachycardia means that somewhere within the ventricle, the main pumping chamber of the heart, there is a small irritable focus which has a tendency to fire off and cause a rapid arrhythmia, which may cause you to black out or may even be life-threatening. The way in which we treat ventricular tachycardia is to often use drugs which suppress the arrhythmia. So that's another use, for example, for beta blockers. And there are other drugs that we use to suppress the arrhythmia. But in some people that are having recurrent episodes, then we may ask our colleagues, the electrophysiologists, to perform what we call an ablation procedure, which is where they put small wires inside the heart, again, usually from the top of the leg. They try to find where that irritable focus is and then freeze out the focus to prevent arrhythmia from arising from that area of the heart. And that remains the major way of performing that procedure. There are other ways of doing it. I spoke about alcohol ablation, and there has been a vogue for putting in catheters into small branches of the coronary arteries which feed an area which is irritable, and injecting alcohol into that area. So actually doing a localized ablation elsewhere in the heart. There's a new technique which is actually using ultra-focused radiotherapy in the heart, which is being used as a precise way of treating cancers, but which potentially can be steered to a single focus in the heart muscle. So there are other potential ways of doing it, but the overwhelming majority of cases would still be done using these catheter-based techniques. This is an important question. So how do we, it's just been deleted. Oh no, it hasn't. How do you diagnose burnt out hypertrophic cardiomyopathy, and what's the prognosis and treatment? I mean, if there was something designed to make you lose all hope about your future, it would be to describe your condition as burnt out. What we mean by that is that the pumping function of the heart in hypertrophic cardiomyopathy is reduced. When we do an echocardiogram of the heart, we measure the difference between the heart when it's contracted and when it's relaxed. And that we call the ejection fraction. And a normal ventricle would eject at least half its contents with each heartbeat. So a normal ejection fraction would be 50% or more. Now, characteristically in people with hypertrophic cardiomyopathy, the ejection fractions are abnormally high, 70% or 80%. And that's rather loosely, we sometimes say that's because people have hyperdynamic or hypercontractile or supernormal function. That's not quite correct. What it means is that because the heart is very small, it doesn't actually have to move very much to eject its contents. But if we follow people over a period of time, that could be 5 years, 10 years, it could be 20 or more years, what we see is this ejection fraction may go from 75% to 60% to 55%, and then below 50%. And people have used this term burnt out or end-stage hypertrophic cardiomyopathy to describe that phase. People may have symptoms in that phase. They may be completely asymptomatic. but it's just a warning sign that we maybe need to think about switching therapy from some of the drugs that I've described for treating outflow tract obstruction, for example, drugs that reduce the contraction of the heart, to drugs which, if you like, help relax the heart muscle in a different way, the kind of drugs that we would use in dilated cardiomyopathy, so ACE inhibitors or spironolactone and those kind of drugs. It signals a change in treatment. That is the frontier that I was talking about. That's where we really need new therapies. So again, great question. Do we know what factors can influence whether someone who carries a 40 gene goes on to develop condition? As I showed you, we and others have shown that if you carry the mutation, on average, about half the people who carry a mutation but start off with nothing will develop the condition. So why do the other half not develop it? We have clues. There's a difference between genders. So if you're a male carrier of the mutation, you're much more likely to develop thickening of the heart muscle than if you're a female carrier. There may be an impact of ethnicity. There may be an impact of having high blood pressure. But in truth, we don't fully understand why this is. And you've got this single spelling mistake in a gene, but you've got another 25,000 genes. So it's likely that the rest of your genetic makeup also contributes to the risk of developing the condition. But it remains a very important area of research, trying to understand those factors that turn on a gene and make it express itself. A quick one, do we use Entresto in HOCM with heart failure? If you've moved into that phase where the pumping function is down, possibly. We have no data, but there is in fact a trial which is starting with Entresto in people with hypertrophic cardiomyopathy. Is atrial fibrillation a common complication? Yes, as I've shown. Is there any special treatment? We sometimes send people for what we call an ablation, where we try to burn a little area in the atrium, the top chamber, so we prevent the atrium from going into fibrillation. That can be successful, but it's less successful in hypertrophic cardiomyopathy and other conditions, and often requires 2 or 3 goes and may not persist over time, but it can be helpful in some individuals. As I've said, I mean, I'll take this one maybe as a last one. It hasn't received any votes, but are there any new developments in the understanding of treatment, genetic testing for apical HOCM? I'm going to extend that and just say that, when I talk about the future, I really am very optimistic, because it's literally within the past 5 years that pharma companies, biotech companies have been really focusing on hypertrophic cardiomyopathy and some of the other rarer heart muscle conditions. And we're seeing drugs which are targeting completely new aspects of the condition. We're seeing the repurposing of old drugs. And we're even now starting to talk about gene therapy as a realistic possibility. Can we correct the underlying genetic problem which causes the condition? Now, there are many issues with regard to that therapy, but the same ideas have been used in other conditions. They've been used, for example, in muscular dystrophies, in haemophilia. They're now being trialed in patients who have some metabolic diseases, some of which can cause cardiomyopathy. But there are now some interesting studies starting to happen in people with hypertrophic cardiomyopathy. And this gives us the possibility of preventing the disease. Taking people that carry these genetic mutations and actually giving them a therapy to prevent the development of the thickening and of the scarring in the muscle. So I think every reason to be hopeful, and I think it's going to be a really exciting and interesting time in HCM. Thank you very much for listening.